to 10 minutes, I think.
No, don't do that, Ed. I have a call at 12.
Good, how are you?
Okay, well, while you're getting seated, let me just introduce myself. I'm Bede Sondik. I'm the director of the National Center for Health Statistics. And I might say we have something like a strong vested interest in all of this, as you can imagine. I was very struck by the first session, though, which gave vision, more than one vision. I think multiple visions of what this is all about, and I think a strong sense of what can be achieved. I'm a great fan of David Letterman, and I don't have a top 10 points that came out of that, but I have something along those lines. And since he got the Kennedy Center honors, I feel it's okay to bring him up in an august setting like this. I was struck by, actually, I walked down the hall, and I won't take a lot of time because I'm just the moderator here, but I walked down the hall into this is the first time I've been to the center, and I looked at the Beckman museum or exhibit, and I think it's entirely appropriate that this meeting on measurement be here. And just walk down there and think about what those advances in measurement wrought in fields that went beyond anybody's thinking at the time. I was just tremendously impressed by that. We're talking about, I think one person, George, mentioned standards, and I'm not sure he meant it in terms of standards, at least as I think of standards, but I think that this is critical in when we talk about these measures. I think standards are quite critical. I think we are dealing with a complex system. And as you hear this session, I would think about healthcare as a very complex system and how all of this fits together. I think the point about Gilbert raised a dimension that doesn't always come up when we talk about health. Some years ago, I got converted, I think, to thinking about health in terms of functioning. Okay? And it's a very important, I think, approach to thinking about what health status is. Okay? And it's not something that normally or typically comes in as we think about overall summary measures of health. I think the point about integrators or integrator, to me, what I took out of the session was we're really talking about a system or a network of integrators at different levels in the 4 levels that Michael laid out in the beginning, national, state, local, and institutional. And I also thought the point came up a bit obliquely, but I think it's important in this session to think about the different population groups. That's an entirely different dimension than thinking about national, state, local, or cost, quality of care, and health outcomes. And think about an integrator perhaps for each population group and how they all fit together. Well, I'm really taking too much time on this. Last point came up in a question, which was about parsimony. Parsimony makes me, as a sort of data person, nervous, because that says we're going to deal with too few, one might say, indicators. But it's really not that. It really should raise, at least it raises for me, the idea that we're talking about a set of indicators, measures in which we can drill down. And the measures that are highest are the ones that stimulate the integration, stimulate the discussion, stimulate our question about how healthcare cost, how it all fits together. So in this session, we begin with where we are, okay, and think about that in the later sessions in terms of needs and infrastructure, and then what it is we actually do to try to implement all of this. We have 3 very distinguished speakers today. If they don't mind, I'm going to introduce you all right now so we can move right along. And I think they really don't need an introduction. So I won't say that I won't introduce them, I will. Carolyn Clancy is going to be our first speaker. And I think everybody in the room knows her as director of ARC since 2003. She was reappointed in 2009. She can tell you about her future. It's not for me to say. She's not even smiling. Prior to her appointment as director, she was the director of ARC's Center for Outcomes and Effectiveness Research, and her major research interests include improving healthcare quality and patient safety and reducing disparities in care associated with patients' race, ethnicity, gender, income, and education. Helen Burstin, Senior Vice President for Performance Measures of the National Equality Forum. She's responsible for the NQF consensus development process and the endorsement of performance measures, practices, and frameworks. Prior to joining NQF, Dr. Burstin was at ARC, where she directed the Center for Primary Care, Prevention, and Clinical Partnerships. She oversaw the development of a research portfolio at the intersection of health IT and healthcare quality, and produced an extensive body of research on primary care and prevention. She's a board-certified general internist and Precept's internal medicine residents at George Washington Medical Faculty Associates. One of the things we didn't hear about this morning really was the role of technology in all of this. And for one, I think that we really are at a cusp in terms of this and what we're going to be able to gain in terms of measures in the future. Barbara Gage is our third speaker. She's Managing Director of the Engelberg Center for Healthcare Reform at Brookings. She's a national expert in Medicare, post-acute care policy issues, including bundling payments, episodes of care, and case mix analysis. She earned her PhD in Health Policy and Administration from Penn State and her MPA in Public Administration from the University of Maine at Orono, pardon me. So let's move to our first speaker, Dr. Clancy. The speakers are going to have 10 to 12 minutes, and then they will be summarily yanked from here by the light over here. And then we'll have probably about 40 minutes, I think, all told for discussion.
Great. So that was not part of my time, just to be very clear about that. Well, good morning. Good morning, everyone. I must say that George and Maureen were quite a tough act to follow and really, I think, set the stage for our conversations today. So the National Quality Strategy, 3 broad aims, no surprise to very consistent with the triple aim. I think we referred to it as the 3-part aim, and there's a longer story there, but I won't even go into it. But essentially it goes into better care, better health, and care that is affordable, and I don't need to or particularly want to embellish on Maureen's very articulate description of that. I will make 2 comments, though, just about the context. One is that the first question we had to get our heads around was, what did national mean? Because after all, we are the federal government. We're national. And did that just refer to HHS programs and what's under our direct control? Or was it the messier and arguably far more important challenge of actually working collaboratively with private sector partners? And that was a very interesting set of conversations because it's riskier to actually have to share accountability and when you don't actually have control over what your partners are doing. But what we concluded was that we definitely needed to think of, since the vast majority of healthcare is delivered in the private sector in this country, that this had to be a newly a redefined version of what a public-private partnership could look like. The other context that I think is very, very important is we noticed when we developed version 1 of this strategy, and I'm going to tell you it was really geeky and technical, and we loved every syllable in it. But in communicating that to an audience first of colleagues at HHS, some of whom are breathtakingly smart about nuances of finance and access and so forth, I'd have to say they had a lot of constructive comments, like, what is this all about? Together with their help and feedback, as well as incredibly vital input from the National Priorities Partners and other organizations in the private sector, we were able to develop the first version and submit it to the Congress as required by law in 2011. Now, this also requires that the Secretary submit an update every year, which is also pretty interesting. Now, one of the best kept secrets of the Affordable Care Act is just how many provisions in there relate to improving quality and care delivery. I haven't done the page count, but it is a huge, huge array, and that doesn't even count all the work that Kevin Larson and his colleagues at ONC, with many, many others, are doing on high tech. That's a separate piece of legislation. Fair number of those provisions, in fact, quite a few pages, actually direct Kate Goodrich and others at CMS to keep doing everything they're doing now, but do more of it faster. So it's not as if we get to start from scratch. And I think as we're thinking about core metrics, and the timing for this workshop couldn't be better, we've got to remember that we're not starting from scratch. So it's a little bit like changing the tires on the car as you're hurtling down the highway in a rural area, okay? Saying that in Washington doesn't have any meaning because we don't hurtle down highways, we crawl. So what we did, again, with lots and lots of input, was to identify 6 priorities, which are shown on this slide. Top of the pile by design is patient safety. 2 priorities speak to engaging patients and families as partners in their care. One speaks to promoting evidence-based treatments for conditions that are the leading causes of mortality, starting with cardiovascular disease. Another builds very heavily on work of CMS and public health colleagues, working with communities to promote the widest use of best practices to enable healthy living. Notice how that rolled right off my tongue. And the last, of course, not by design, is making care more affordable through innovations in how that care is provided. I will also note that since we have the honor and privilege of reporting to the Congress every year in terms of how we're doing, I will simply say that we have reoriented our annual reports on quality and disparities, as shown here, to really align with the national quality strategy priorities. I do one more word about the context, and not only do we not get to necessarily stop what we're doing, even parts of it that we might think would be okay if we stop doing it, not if it's required by law, we're not going to stop that quickly. We're in the midst of a couple of big transitions. One is from counting the countable to counting what's important, right? I mean, I heard someone say a few years ago, well, we can't do X because we don't have a database. And actually, she was exactly right. I'd never stated it quite that way, but she said we got out of the gate on long-term care measures because we had this database, and that's why we did it. Not precisely, but as the white paper says very articulately, measurement and policy goals ought to drive the infrastructure, and we're in the midst of kind of turning that on its head, rather than trying to figure out how do we make sense out of the data that we got. Some of the key measures, whoops, I think I skipped one here, and long-term goals. So I've now shown you the same slide twice, all right. There we go. So this is just a picture of the first annual update that we were able to submit to the Congress. I'll just say we were very, very excited, and it highlights efforts in Colorado and Ohio to improve quality along these 6 priority areas. Some of the new initiatives, I know many of you are very, very vital participants in the Partnership for Patients. I don't think our lives at ARC have been the same since this got started, largely because we now have an incredible new and much, much broader audience for the tools and practical strategies that we've been developing over the years, before that only known to a relatively small, elite, very loyal group and enthusiastic. But now, I think what's incredibly exciting about these national scale initiatives is that you know, across the country, people and organizations who I think were in the pre-contemplative mode have now shifted to saying, I want to be part of this, and how do I do that? We're also learning that sometimes we have to shift gears and be willing to work with them to figure out how to adapt, because the answer to how do I do that is going to be different among the early adopters than it is among those who adopt later. Now, some of the key measures and long-term goals are just shown here, and I don't want to get into this, but more to say that the timing of measures. So what we can count right now is the incidence of measured never events or healthcare-acquired conditions. Ultimately, we'd like to reduce preventable readmissions and so forth. And you can see here that when you look at the prevention and treatment of leading causes of mortality focused on cardiovascular disease, you know, the short-term goal is increasing aspirin use from 47% to 65%. In the long run, we're going to need all of these other community interventions as well, and figuring out how that factors into our capacity to count and decide what core measures are, I think is incredibly exciting. I also want to support and acknowledge the efforts of Nancy Wilson, who was part of this planning committee, and I'm waving to you, Nancy, because I know she's tuned in by webinar, and Kate Goodrich, who co-chair a council at HHS working on internal alignment across HHS programs. And it's a lot of work. We're all for alignment until it comes down to timing, right? No, we mean right now. And in fact, across HRSA, the Indian Health Service, SAMHSA, other components of HHS, Kate and Nancy are leading the very, very important work of alignment. And you can see it actually when you look at the final rule for stage 2 of meaningful use, right? If you're using an electronic health record, you get credit both for the meaningful use incentive and the physician quality reporting system. Now that's a fairly atomized example, but nonetheless incredibly important, and by the way, actually brand new. So that's just a very specific, tangible example of why the National Quality Strategy has provided a vital framework to efforts across the department. And frankly, I've been very impressed by the fantastic collaboration that's ongoing. Now, just to close on some ongoing challenges. Uniformity in measuring. I think both the how and when are we going to do this? Yes, at what date certain are we all going to be using the same uniform metrics? And when is it important to be uniform, and when does it not matter? Because what's actually going on throughout the heterogeneous communities and delivery systems across the country is that many people are seeing for the first time what happens beyond that unit transaction that Maureen described, right? Hospitals are seeing for the first time just how many silent partners, you might say, that they've had in terms of where people go after they're discharged and so forth. And that's all brand new, right? And sometimes they're finding that actually patients discharged from one relatively medium-sized hospital might be actually discharged to hundreds of skilled nursing facilities. Wow, they had no idea. They didn't need to before because your job was done when you got down to the lobby or into the ambulance at the next stage. Another issue that is very real for us with the national reports is the lags in timeliness of data, right? So we're going to go out with a report labeled 2012 in a couple of months. We're very excited. It's a broad cross-department effort and could not be done without Ed Sondik and his colleagues. But at the same time, that's lagging behind what's happening right now, and people are understandably going to feel a little bit frustrated by that. And the other piece that we have, I think, is are we actually collecting the kind of data that organizations need to make rapid real-time improvements? Probably our best example of this is actually the Keystone Project, then expanded to a national sort of quasi-demonstration to reduce central line associated bloodstream infections, right? I am convinced that a key part of that was very light data collection and quarterly feedback. The folks in Michigan are now convinced that quarterly is actually kind of a lame goal. But if you think about most federal and state and policy initiatives, quarterly is really, really great. Imagine knowing how I did this past quarter. Because when you can begin to connect the dots between what I'm doing every day and the goal we're trying to achieve, that itself becomes sort of a kind of rocket fuel for continued work and engagement and continued work when it starts to get tough. So I'm going to close with a quick story, and yes, Ed, I do see the light on. This summer, my husband and I visited with a couple in Wisconsin, long-standing friends of his, and I knew that my husband's friend's wife had had a stroke a few months earlier, and I had not known her before, so I didn't even know what to expect. I had heard she was doing better, whatever that meant. The bottom line was she was doing great because they don't live terribly far from a university hospital, 5 or 6 miles, and the night she had a stroke at home, all the pieces, all the dominoes fell just the way they're supposed to. She got timely administration of a clot buster and walked out of the hospital completely back to where she was before the next morning, which was quite amazing. But when you listen to our friend's story, it's also quite amazing because he's not reporting on each little component. He's pathetically and, grateful every minute of his waking day that his wife is okay. It's just the two of them. And when he recounts the story, actually the 911 responder probably did more to help him right away. He heard a thud in the other room as his wife hit the floor, went in and saw that she was paralyzed, was very lucky that he didn't actually have a stroke on top of her. He was terrified. He calls 911 and gets a very reassuring voice who explains to him, please leave the door unlocked, we'll be there quickly. And do you have a dog? And if so, can you put the dog in their little condo or whatever you put dogs in? So that, the dog doesn't bite the people who come to your home. He did all that, and they got to the hospital in a timely fashion. When they got to the hospital, there was a neurologist right there. She got timely administration of this treatment, and that's all how it's supposed to work, except most of the time it doesn't. These days, we tend to measure each little piece of that, right? And we often don't measure things like, was the neurologist who was supposed to be there actually there, and so forth, right? But the core metric might be something like door to balloon time is for heart disease, time from arrival or time from symptoms, and what percentage of stroke resolution we've got. But we need those other metrics too, but I'd argue we don't need the uniformity. We need them because everyone needs to see what their piece of it is so that the symphony plays as it should. At the same time, I don't think that we need to over-specify that with uniformity and precision. I don't really care if they do it the same way in Madison as they do in Minneapolis or here in Irvine, but people do need to have some sense of how they're doing and could they be doing a better job. So I'm totally with you, Maureen, that I think that the notion of core measures can be a very potent force for driving alignment and integration. Right? Alignment is not a technical exercise. It's really about how does my job relate to yours, and that is very, very new business for healthcare. So thank you to the organizers for this workshop. Timing is fantastic, and I look forward to our discussion.
Dr. Burstin.
Hi, everybody. It's a pleasure to be here today. I will point out to Carolyn, we just endorsed the time to balloon time for stroke very recently, so agree completely. So I was given a challenge more so about where we are right now and what's the logical path to where we want to be. So I'm a little bit stuck in the current, but you'll hear, I think, some threads of where we want to go. I'm supposed to be on key challenges and opportunities. I love this quote, actually attributed to Albert Einstein, although as I looked it up this morning to try to use it in a paper, it's not actually clear he said it, according to quoteinvestigator.com. But he clearly had a sign in Princeton in his office that said this. And I think it's really, to me, it sums up, I think, where we are today, which is that not everything that counts can be counted and not everything that can be counted counts. We're kind of in this funny place of a lot of measurement that doesn't particularly move the needle of where we want to go, and not a lot of clarity of how to capture what we actually want to capture that we think will move us in the right direction. But we also can't forget Deming's wise words that we can't improve what we don't measure. So we are in this sort of, I think, interim space, and I remain very optimistic, as I usually do, that we're going to get there. So I'm going to give you a fairly high-level view of where I see, again, as somebody who watches hundreds of performance measures come through our door every day, what's out there, what's changing, what's evolving in terms of performance measurement. So the first thing is I think we're beginning to see a real drive away from process measures reflecting the standard of care, which were kind of part and parcel of much of the initial work of performance measurement, moving towards measures that really reflect high levels of performance. The harmonization push now has become huge, and it's been raised multiple times today. Harmonization, alignment, whatever the right word is, getting us at least using a common concept to move measures forward across sites and providers. There's definitely a shift towards both outcomes and composite measures, as I'll talk a little bit more about. And I hope we are finally, as somebody who was delighted to work with Carolyn in my earlier days and led the first disparities report, finally at the point where the data systems will allow us to measure disparities in all we do, not as the afterthought that it has unfortunately become for our nation. I think we're also beginning to see, and I'm actually excited, I think, with Judy and Kevin and others in terms of thinking about what HIT can do, the potential for that longitudinal measurement, really being able to follow patients across what they view as their patient-focused episode, as we heard so elegantly stated this morning by Maureen's examples. And that naturally leads us towards outcomes, including patient-reported outcomes. We've been doing some important work there, I think, of trying to think about how we move those measures into real-time practice. Measures of appropriateness and overuse, which we haven't talked a lot about today, but it's hard to imagine bending the cost curve without them. And then again, how can we imagine looking at cost and resource use unless also coupled with quality measures? So you've already seen the triple aim, just to make the case. If this is where we're going, we're not there yet. But we do view this as our true north, and I think we need to all work collaboratively with measure developers, with EHR vendors, with all of us together to really say, how do we achieve the measures that actually allow us to measure where we are and achieve that triple aim? Some of you know this is how we look at measures in terms of the measures that come forward to NQF for evaluation, and I'm not going to get into the weeds on this. I will say these really do reflect the principles of what should be a good measure going forward. So we really want to make sure it's important. Why bother collecting something if it's not going to drive improvement? We need to get beyond that. We need to really make sure there's an opportunity for improvement. We need to make sure that those measures are reliable and valid. We shouldn't be measuring noise. We should be measuring real performance differences so people can drive on what's important. We just updated usability and use this past year, and I included a little bit more detail here because I think it's really important that we're actually at the point now the full language says performance results used for accountability and improvement to improve the health of populations. It moved away from being just patients to populations. And we also now, given where we are in measurement, it's not only about facilitating improvement. You want to see that these measures are having an impact, but are they also having a negative impact? And we're unfortunately seeing too many examples of measurement driving what we don't want it to drive, and I think we need to be cautious of that. And of course, they've got to be feasible. We've got to think about how to move these into electronic health records and systems in a way that makes sense. And because of harmonization, it's hard to imagine how we do that without thinking about competing or related measures. So here's my sense of where I sit in a multi-stakeholder world, just two very different perspectives. And I didn't list all the stakeholders, but just in general, we clearly hear from clinicians and providers in particular, lots of concern about how this measure will be used to assess my performance. A lot of concerns that they want to stick to measures they feel they have more control over, where they can have actionable processes to drive that improvement. And a lot of concern about getting too close to the outcomes flame still, although I think with better risk adjustment, we are starting to see more movement in that direction. And a lot of concern about measurement burden, as I'll show you in a moment. From the side of the consumer side of those who purchase care on their behalf, continued concerns about, are these the right measures? Are these the ones that are really going to show impact and value over time? They want outcomes, they want composites, they want to move away from those process measures, and the common mantra I think we've already talked about today, not letting the perfect be the enemy of the good. Those are really poles of where we sit, and I think we're in a very difficult spot still at the moment of trying to figure out how to find the path between those that allows clinicians and providers to have the measures they view as being important for improvement, but having measures that are a higher altitude that allow us to see, are we actually going towards our North Star of what we want to improve? We've done some work over the last couple of years for our evidence task force and really have finally stated with as clear as we can that there's a hierarchical preference for outcomes. Bring us your outcomes. Don't bring us the distal process measures that aren't going to actually move the needle in outcomes. You can measure them as much as you like internally if they're useful, but they should not be the measures that we're going to align on or move forward on that are really going to drive our improvement. And so really trying to push on this concept. And also, as we push on this concept, though, we are really in a supply chain of evidence. And so oftentimes we would love to have measures that really get closer to outcomes, or intermediate outcomes at least, but we are still at the point of not having clinical guidelines that have clear descriptions of benefit and harm, have the quality, quantity, consistency of evidence that we need to develop performance measures. And we are still in that chain, and unfortunately conflicts are still very real. So this is a slide a colleague of mine shared with me, and it's just, as she called it in a talk that we did together recently, the tsunami of measurement. And so it is, I finally have learned, it is animated. So this was just a sense of, if you start adding on all the measures that her system is required to do across the federal, the state, the different programs, it does start to feel like a tsunami. And so her point was, all their attention is now paid to measures that don't necessarily drive improvement in their system, but they have to do them. And so the question is, how do we move towards pulling in only those measures that actually are going to move that needle and trying to have some of the others, left out the one on the side there, the others potentially align or be removed over time. And to George's point earlier, I think we also have to think about how we move towards measures at different levels of the healthcare system. We need to at least have some alignment that allows us to have a national sense of, for example, in this example, smoking cessation. How does that relate to the data we'll get out of, for example, state BRFIS at the state level? How does that relate to what health plans, ACOs are doing, and then finally down to clinicians? Do they have to be exactly the same? Not necessarily, but they should at least align on the science. We want to make sure we're measuring things the same way. We don't want people reacting to noise. We want them reacting to real information. And this, I think, is a challenge for all of us going forward. And this is where we really oftentimes hit very hard into this issue of harmonization and competing measures. There is a real industry that has been brought up over the years with very siloed measure development in different sectors. It's very hard for people to break down those silos and be willing to give something up. But I think we want to get to the point where we avoid duplicative measures that increase burden and don't add value. And we really want to, especially with the hope of interoperable systems, begin to measure only where and when it's really most important. We are constantly measuring things in every single setting for fear at some point we'll pick up the quality signal because we're not assured we'll actually get it over time. And just as a personal anecdote, my dad passed away a few years ago and was very, very sick in the hospital with septic. And the nurse came running back in, and I was hoping she would recheck his blood pressure because I thought he looked kind of gray and I was about to grab the cuff myself. And instead she ran in and said, "Mr. Burstin, have you had a pneumococcal vaccine?" Really, wrong time, wrong place. Let's think about where this should be. This shouldn't be in the acute crisis moment of a parent who's that ill. So we've really tried to think about some ways to work with developers, work across the sectors of saying, what is competing measures? So we could really eliminate that duplication, same measure focus, same population, make it one measure. Eliminate the duplication. And when are they related, like that cascade I showed you from national to clinician, where instead we really want to be able to say, align on the science. The measure doesn't have to be exactly the same, but we've got to have a sense of where we're going overall. And then, of course, it's hard to talk about where we are now and where we're going without talking about this transition to e-measures. We are very much in this interesting place of trying to figure out how we move there. We need to stop taking the measures we already have and trying to jury-rig them to fit into a system for which they were never developed. They were developed for claims. They were developed for paper medical records, and I think it's time to really start thinking about it. I know ONC and CMS have incentivized this. How do we move towards that de novo measure development that really takes advantage of what's the better clinical data and other data that's available in EHRs, in clinical registries, and also in patient portals. We won't get to patient-reported outcomes unless we begin to really integrate in those data streams from patients, those data streams from registries to get the outcomes, and the data streams of what we already have in our electronic health record. We also need to have better interfaces that allow us to pull in those demographic data to look at disparities or to look at geographic geocoding, to go back to the Memphis example earlier of really being able to see where in your community there are particular populations at risk, but also to pull in all the cost data, which isn't going to ever live in an electronic health record, but needs to somehow be aligned and brought together. And we need to ultimately, our mantra for a long time, get to those interoperable systems that allow us to track quality, performance, and efficiency across sites, across providers, across data platforms, thinking about that whole patient of where they live and where they're going. And there's no question there are issues with our current EHRs, plenty. We are not yet at the point of having a lot of data available to really test and see where we are in terms of data systems because they are so highly variable. But we also know that we need to move towards those advanced measures, and yet we don't always have the systems in which to test them because we want to stay ahead of the curve. So definitely an interesting place right now, but I think we want to stay towards where we can bring forward those measures that really help us satisfy the national quality strategy. So it's a great slide I've used for years, and from Aligning Forces for Quality, because I think it's such a great illustration of even if we had electronic health records, even if we could pull in the claims data, we still have this real need to think about the patient at the center and pulling in from a very patient-centered view their information from pharmacies, from claims, from registries and others to really be able to get that full view of the patient from where they sit, rather than always, you're sitting in front of me, I'm talking about what I did today. Did I give a pneumococcal vaccine, as opposed to have you received a pneumococcal vaccine? And just a little bit about usability. This is an old concept developed by Berwick, James, and Coy years ago that was recently updated a few years ago in the Annals by Fung, of this idea of course, measurement is not an end in itself. It's really our intent here is to improve quality, but it is still these two systems to a certain extent. Having this public reported data certainly can help improve knowledge, but there still is a set of measures that tend to be used for selection, or at least payment, and a set of measures that are still being used to drive improvement. And I think the real question is, how do we ultimately figure out what that core set is, thinking of cores, that allow us to figure out the set of measures that actually can work for our accountability purposes, but are also ones that will be useful for improvement. Because if they're not useful for improvement and you're just checking a box and then going back and doing your improvement measures, we have a real problem. So I think really thinking about how that core can serve two purposes is going to be important. And I just did this slide because we tend to always think about the measurement framework and pipeline as being very linear. And in fact, to really make progress, it needs to be circular. So, the measure developers are out there, like Mary and others who are out there doing great work developing measures, come through us. We work with the developers and others to standardize, harmonize, work out the electronic data platform, the underpinning of all of this. We select which measures make the most sense for use. Ultimately, those measures get implemented. What we don't tend to do is the orange box there. We don't assess the impact. Which of those measures worked? Which of those measures haven't worked? And let that feedback then drive us forward. Those measures should then really not be used, and we should really be bringing in newer measures. We've started doing that. Any time a measure is up for maintenance, we call for implementation comments, saying, has this measure done anything? Can the developer provide evidence it's actually moved the needle? But it needs to be something more systematic we do as a health system. We should always be learning from what we're putting out there, asking people to measure and really say, is this helping you? And if it's not, what are you using internally at Health Partners or other systems that has helped you move that needle, like the cost of care measures that we endorse from Health Partners, and bring those in and think about how those become part of our rubric of measures for accountability. This was a slide, I know Sheridan's here, I borrowed from Liz Mort at Partners because I thought it was a great distillation of where we're going. She called it the scope of future measurement, of really beginning to think about value for patients at the center there. And I thought these were just some very nice definitions I won't go through in my last 48 seconds here, but I thought it was a very nice visualization of cost over an episode, outcomes over an episode, defined by the patient, with value really being at the core of it, of outcomes over the cost of delivering those outcomes for patients. I thought that was a really nice visualization of it. And I also just want to think, as we're also in this place, we're also thinking about where we want to go in the context of a very constantly changing delivery system. This was some, I thought, really lovely work done by the Commonwealth Fund a couple of years ago, looking at the continuum of bundling on the y-axis and continuum of the organization on the x-axis. So things that we thought were not feasible currently become much more feasible, like outcomes and care coordination kind of measures when you have that continuum. But we also just need to recognize that as we move towards these different models, measurement needs to go along with it. We need to start thinking about how measures for bundled payments might look different. What might those unintended consequences look like when we bundled payments that we also need to keep top of mind? I'm done. Thank you very much.
Dr. Gage, you surprised yourself there.
I never played basketball. The shot clock confused me. I thought I had that much left or that much more. I don't know.
Well, I'm not sure I can speak as fast as Helen, but I'll try.
I definitely can't.
Only Lisa Simpson can.
All right, so I was asked to speak about some of the implementation issues. You've heard about the measures, the development of the measures, and the variability around the country. I'm going to focus on the actual implementation and moving towards the triple aim. What are some of the things to consider? So we know that there's a changing landscape. There's a lot of relationships being developed with or without navigators. There's a lot of, each of the different initiatives are trying to pull in performance measures, and as Helen mentioned, some are actually useful for measuring value, and others are just more traditional measures of quality. The science behind the measure development, while it is good within the measure and the whole framework of developing measures and having scientifically reliable work, it gets a little more complicated when you start trying to apply it either across different groups of organizations that are working more independently but are now being given incentives to collaborate, or across payer groups where you have a few other issues that you need to consider. But as you're moving towards improving the community's health, you really need to deal with some of these issues. And so that point of aligning the measures within and between the different sectors is very important. So where is the measurement landscape? We have the what does it mean to align the measures? There's a lot of discussion about measures of quality, measures of cost, and there's even agreement sometimes on what that measure should be. But when you try to take the system that is based in one organization and look at the measures coming from them along with the system that is based in another organization, potentially with different electronic systems, you really do have to have alignment in the specification of the items, because you're talking about merging data, and in order to do that, you need to be merging apples to apples. So item specificity becomes quite important and is often overlooked as everybody talks about, well, what should we be measuring? The other issue that's very important and hasn't had a lot of attention yet is the consistent and timely feedback information to the clinicians. If we're actually going to change healthcare and reach those goals, we don't need to just be reporting data, we need to be feeding it back to the clinicians so that we can change the behaviors. And the broader, faster implementation of comparable, meaningful measures for quality improvement, reporting, and payment. So each of the groups have their different goals, perhaps, but they're all in it together, moving towards this triple aim. So in today's framework of trying to move us forward, we have the National Quality Forum working on what are the measures, what is the scientific basis. We have the payers, both the public payers and the private payers, selecting measures that they think are appropriate for their programs, and beginning to have discussions across payers so that they're thinking, they're talking together about how do I want to measure quality, how do I want to measure cost, what do I want to measure. But we are at the beginning of those efforts. There are a lot of initiatives underway that are targeting two different sets of issues that need to be considered as we're thinking about the community's public health, and that's the measure implementation across providers and populations, which I mentioned earlier. But when you look at the range of initiatives that are out there, it's not just the Medicare ACOs or the self-forming ACOs, it's not just the AF4Q. There are communities, the collaboratives, everybody, there's a revolution going on, and you need that communication across the groups in terms of these implementation issues as well as the measure development. And secondly, the data issues. This is not the prettiest part of the picture, but it's the most important to the success, and really thinking about the different data models that are available and how you can approach data submission, returning data to the providers, the whole range of the uses of the data. There are a few efforts going on trying to work through these issues, and they have different numbers or types of providers involved, but each time you add another organization, you add a complicating factor, and hopefully we can establish a strong enough framework of what those factors are to be examining that we can start having solutions as they try to address them. Some of the work that Carolyn and Mark McClellan have been leading with the Quality Alliance Steering Committee is really focusing on several of these implementation issues. You have the whole issue of what measures should be selected, not what is a good measure. NQF worries about what is a good measure, but in thinking about the range of concepts that could be applicable and winnowing it down to those that reflect value, not just quality, and thinking about the range of measures within those concepts, and then thinking about the different specifications of what it appears to be the same measure. And I'll put up some slides on cost in a minute to give an example. There's a lot of discussion about the quality measures, but value has both of those components. It has the clinical outcomes work as well as the associated costs, and you don't want to think about one at the expense of the other or vice versa. Secondly, the issue of the data transfer. I've mentioned the issue of standardizing the provider performance, and Carolyn raised some good points about how do you do that and allow the local preferences to factor into the efforts. At the beginning of a revolution, you really need to think about what is the core, what is the framework on which we'll be standing. But you also have to think about that issue of merging the data across the different IT systems. And as I mentioned, each of the different organizations within that collaborative or that ACO or whatever you want to refer that accountable entity, each organization has its own IT platform. And to bring it down to simple terms, you're talking about my IBM and your PC or your Mac being able to exchange data about that patient as they cross across the episode of care. And you're not within a health plan. You don't have the advantage of we're all on the same IT system. But you also have to think about the different sources. Much of the work thus far has been based on claims data, easy pickings, easy to do. There's the incorporation of the registry data with some of the physicians' work, and there is also a great opportunity in the rest of the patient's episode. If you think about the high-cost patients who you really need to manage in order to improve the quality of care, you're talking about the patients that Carolyn mentioned. They're going from the hospital, from the doctor's office to the hospital, to the skilled nursing facility, possibly back to the hospital, out perhaps to specialized rehab services. Each of those types of organizations have separate performance metrics and different IT systems and different approaches for collecting, standardizing, and submitting that data. And Kate has been leading the work on moving some of those issues forward, but we have a long way to go before we're really talking about the whole system that's serving the patient's episode. As was mentioned earlier, the data governance structures. Easy to say, hard to do, and a lot of the discussions as we think about data models really reflect the data governance and who has the data, who can see the data, how are my data protected. And most importantly, the systems can't be cost prohibitive. So there are a lot of vendors out there developing IT systems and selling their efforts to the different collaboratives. But really, the closer we get to a national effort, the less work is needed to be reinventing the wheels, and things will become more affordable because it'll be very difficult for a hospital to explain to its board that they have to change their entire IT system in order to either report to one of their insurers or to participate in the movement towards the triple aim. The third piece that's very important is the effectiveness of the measures in meeting the triple aim. So this is consistent with that notion of which quality measures are important. In order for the measures to be effective, once those decisions have been made, and it isn't a decision, there is a lot of discussion about core measures, and it varies by community, et cetera. But how do you get that information then back in that timely fashion? One thing we've heard repeatedly is the importance of having measures that are important to the clinician. So it can't just be measures that are developed by some outside body and everybody thinks that's a great idea if the physician treating the patient doesn't see the value in tracking that measure. It's very important and often understated. And then the feedback has to be interpretable. So you can turn out all the data you want. You can have a great IT system in place. But if the information isn't in a graphical form or some form that that practitioner is used to using, they won't be able to use it. And it just diminishes your potential for reaching the triple aim. So briefly, I'm going to talk about the variation in the measures that are under the different insurance programs. Under the ACO, you have 33 required measures of patient experience, care coordination, the 6 aims that Carolyn talked about earlier. And the sources come from things like the CAPS data, surveys of the patients, the claims data, and some of the clinical sources being entered directly into the system. The Medicare Advantage program, the health plans that participate in Medicare, have a different set of measures that they're reporting on. So now if you think about that community focus and the intervention of the community, you're already creating a little bit of chaos. Some of it is due to the different types of services or the appropriateness of measures for different populations, but it does vary. And then we also spoke with AHIP about some of the measures that are most common across the private plans. And again, you have even a different set of measures. Some are in complement to those, but others are different. And then when you start talking to the regional health collaborative. So the point is that that tsunami of measures is really washing over the healthcare environment. The importance of the different data sources and being able to create a measure that takes into account the different sources, I want to just put some flesh around what that means for those of you who aren't researchers. The patient experience, there's a lot of data collected through the CAPS surveys, and they're very good surveys for collecting information on experience. Mostly in plans, some subset to particular providers, and really getting down to that provider experience is what drives the change. There are also patient experience and outcome measures that there's a lot of discussion about patient-reported outcomes. That work is still evolving, but that gets at the patient experience. When you start talking about the costs and the utilization, you're tying back to the claims data. And then when you start thinking about some of those QI efforts, you're talking about the electronic health records, you're talking about the IT systems, and each of them are in development. The ONC has been very proactive in terms of moving standards forward, but there's still a lot of variability, which then goes back and impacts the ability to exchange the data. So, just driving home, 2 sets of issues, the consistent concepts, what are you measuring to get at that value, and the consistent specifications, how are you doing it? So I'm going to put a couple slides up on cost measures because we haven't had a lot of discussion about that. Just as an illustration of some of the initiatives that, or the measures that are out there, I think George mentioned one of his measures this morning. You can see that these 5 different measures are each different NQF endorsed measures, which means their specifications differ. Otherwise, they'd have the same endorsement number. And they're all pretty, some of them are at the population level, some of them are specific to different condition groups. As you think about measuring cost and you think about those simple, that was the very high level cost, there are a lot of factors that can vary. You have the unit of analysis. You can't compare a cost per member per month to a cost per episode. They aren't equivalent. You could extricate it out to the per year, but not per episode. So thinking about that unit on which the cost data are collected is important. Identifying the related costs. Even the work that has been done thus far, a lot of the work in the ACOs is based on identification of a diagnosis on the claim to say, oh, this is associated costs for this patient. Well, that misses a lot of care that is also associated. And so there are a lot of different ways of approaching this. The risk adjustment methods, the issue came up this morning about the comparability and understanding the risk adjustment models that are applied to the different measures is very important because otherwise you could be comparing apples and oranges even though conceptually the label of that measure is very similar. And the privacy protection, when you start talking about cost data, everybody says don't share my cost data. So you have some real issues about the proprietary nature of the data and about the business models underlying the collection of the data and about the individual identification. And there's been a great deal of discussion about different models for issuing performance measures at the community level, whether you take a warehouse approach and have everybody's claims in it, or whether you do more of a distributed data model where the individual providers calculate their measures and forward them to a collaborative or some type of central force. There's a piece that's missing up here. I realized as we were listening to the speakers this morning, the issue of transparency and the consumer's importance. There's a lot of work going on in trying to make information available to consumers that is both actionable and understandable. And that's another factor that when you start talking about costs, what does that individual consumer need to know, or what does that employer's employees need to know? Are you talking about the out-of-pocket costs associated with the different service pieces? Are you talking about the premium costs? Are you talking about just giving an awareness? There's been a great deal of literature recently on making the clinician aware of the total cost of one option versus an alternative. And all of these factors can feed into changing how the services are provided. So this graphic kind of plays on what Helen had up earlier, except it focuses on the data exchange. You have all the different parties who are associated with the treatment of the patients in that community. And when you talk about claims data, everybody can imagine, oh, okay, I either submit my data to a repository or I submit it to a collaborative or my performance measures to a collaborative. Here, when we start talking about some of the EHR data, where you have the underlying variability that needs to be addressed before you can develop the measures, things become much more complicated. And when you talk about the different registries, each of them are collecting different items. And while items sound kind of boring and underrated, they're very critical to this issue of having consistent measurement approaches. So I just wanted to leave you with some thoughts of the complexity of the system and the types of issues that we need to be thinking about as we're talking about moving communities towards the triple aim. That's just, thank you.
It's time to make good use of our resources here. Questions?
Hi, Richard Bankowitz from Premier. Carolyn, your vignette made me think of a couple of observations, and I agree with your point that we need sort of one global measure rather than measuring all the micro elements of the chain, and we certainly don't need to report on the micro elements, but it seems as you go globally with the measurement, that there's a paradox, which is it becomes harder to assign accountability. And so, what you really want is time of first symptom to the TPA, and then because we don't care if you got to the door, but it took you 3 hours to get there in the ambulance. And then moreover, even if the ambulance is fine, if the patient doesn't know enough to call until 4 hours elapse, that's a problem too. But then who owns that whole chain? Really nobody owns it at this point. So it's a paradox, and maybe we can't solve it, but it's something to think about. And the second observation was, it made me think about the importance of balancing measures, which we don't talk about too much, but I know IHI brings this up, and maybe Matt will talk about this later. But if you're going to look at that global measure, you need to make sure people aren't just being sort of shoved into the process without assessment of contraindications. So you want to know bleeding complications, et cetera, and you want to know how many patients actually couldn't qualify because of the delay. So you need to know those things to interpret that measure. So the importance of balancing measures is something we don't really talk about a lot, but I think it's important to think about.
So I'd just say those are terrific points, Rich. Thank you. And you're reminding me that I neglected to speak about complications, but also the follow-up in terms of what's being done next for our friend in terms of preventing the next stroke and so forth. I think the cultural shift that needs to happen is first that we, across healthcare, have to acknowledge interdependence. So I'm thinking that the paradox that you articulated is consistent with the point that George Isham made earlier this morning when he talked about complex systems. The notion that I have to do my part right, but that may not matter unless you do your part right, or it may not have the same impact. You know, that's, I think, a paradox and a tension right there. But I think that's where we need to get to. Technically, I think it's pretty easy. I think the cultural part is much, much harder. We're much more used to thinking about risk adjustment, just do my salami slice accurately, than, excuse me for the bad metaphor. I heard one of my colleagues laughing, but I think it's really, really good points.
Yeah, thank you. I agree with your assessment.
Any other comments? No.
I agree as well. I think there's a lot of work we need to really think about in terms of balancing measures, especially as we look at new payment models. We really have to begin to understand issues around cost shifting, stinting, and unintended consequences. And I think the only way we're going to do that in some ways as well is to get feedback loops. We need to understand what's happening on the ground, and we tend to just not be a system that learns from what's out there in place at a national level. We've really got to start get that information in place.
Thank you. Yes.
Hi, Rob Green from United Healthcare. Great presentations, and it's a privilege to be here. I wanted to add one more consideration to the complexity about privacy that Barbara Gage just brought up. So a lot of my work involves not only performance measurement systems, but deriving actionable information. And in premium designation, our public reporting system, where we have episodes of care, we actually have an online system. Physicians can go down to the service level of information. Now, when you start getting to the service levels and what we as a health plan share with other physicians, we start hitting state privacy rules. So in Minnesota, actually, you can't go down to the service level because you might be showing other physician services to one physician. If we go to population measures, right, where a primary care physician might have a patient who has depression, right? So now if we go down to the service level, or we do the drill downs, which is a terrific idea. I think that's where we have to go. But there are 26 different state rules on sensitive conditions, which conditions are sensitive, and what we can share with a doctor who we don't know for sure already is aware of the diagnosis without getting the patient's permission. If people can follow. It's almost as complex to explain as it is to implement. So I just wanted to make, and we are implementing that because we operate that system in 40 states, and we operate in all 50 states. So anyway, I wanted to make people aware of that complexity. It would be terrific if there were a way that we could standardize some of the privacy rules, maybe in the way that HIPAA does, because I think it will help us when we get to this actionable information.
Thank you. Yeah, important to mention.
Yeah, the only pitch I would make, and this is not for you, it's actually more for other parts of the cast of characters involved in developing and using measures, is it would be much, much better to frame that as constructive solutions for those who are doing the hard work of the policies. Which may or may not move forward. I mean, it may take some persuasion and advocacy and so forth to try to make that case. I mean, what I see very, very often, particularly among certain clinician communities, is just shooting down the measure and then even writing for peer-reviewed journals why this measure is really stupid. Wow, what a contribution. That's all I'm going to say. But for whatever reason, it seems to get a lot of traction. I'd much rather know, and I think most people involved in policy would rather know, how do we fix it?
Thank you. Yes.
Tanya Alteras, National Partnership for Women and Families, and the Consumer Purchaser Disclosure Project. I just want to say, Helen, I think the schematic that you showed, the IHI one that you said was recently revised, really sort of hits the nail on the head. It's something that we struggle with a lot, which is acknowledging that there are quality improvement measures that are very important to just improving the care that's delivered. But when it comes to what consumers need and to what employers and purchasers need, they're not very informative. And so this idea of creating a core measure set that includes those, I struggle with that personally. And I know there have been a lot of discussions lately, a lot of other tables where many of us are sitting at, where we're trying to come up with core measure sets, that the public and the private sector can use together. And it seems these process measures are always in the mix. And it's like, how do we get away from that? I know at NQF, there's a great deal of effort to get away from that. We very much appreciate it. But, with the measure maintenance process, it's still, they still come up. And so one thing, I don't know if this will come up later today or tomorrow in the context of cost measures, is talking about process measures in as they relate to overuse, because that's where I feel like we have a lot more success in thinking about them in a very in a way that makes a lot of sense to consumers, is whether, when these processes are done, it's not just that you check the box, you did them, but whether or not they really were necessary to do.
Right. I think it's a very valid point, Tanya. I think it's really important to not throw the baby out with the bathwater, though. There are some really, really important process measures that actually move the needle. We just talked about one, the new Get with the Guidelines measure on time to thrombolysis for stroke. It's a process measure. Simply looking at stroke mortality isn't enough. You really need to see if that's one of the most important factors in it. You want to keep that. So I think that's why we've been trying to at least keep the dialogue on, keep the process measures that are proximal to outcomes that can move the needle. But the ones that are so distal and 5 and 6 steps away, those are fine if people want to use them internally, but they probably don't rise to the level of being accountability measures.
Well, I guess I would also make 2 other points. One is how we communicate this information to the public so that they understand that some of this is about the specific steps that people need to fix to get to a better place, and also the importance of directionality. Right, and we don't need a whole lot of precision there. The other area relates to, frankly, political governance, right? I'm looking at Secretary Dooley sitting in the back, and I was so excited to have a chance to meet her. I don't even know if that's her actual title, but in any case, to talk about metrics for 2030 on one level is, energizing and breathtaking and really a relief because we don't have to do anything right now, right? Because on the other hand, your leadership, your principals are going to want to know what kind of dent did we make. So that's all part of this complex mix as well. Are we actually heading in the right direction and so forth?
Yeah, again, it goes back to the system and actually having an impact on outcome. Yes.
Hi, Howard Bregman from Epic, the EHR vendor. I'd like to pin you down on this issue. The topic of this talk was the current state of quality measurement. And given the whole world of measures as you'd like to see it, how good are the measures that we have now? And when I say good, I essentially mean how good are they in representing reality? Yesterday morning, I happened to be at UCLA, and I heard recently that UCLA got an F from the Leapfrog group. Now, you can dispute the methodology of the Leapfrog group, but it's ostensibly supposed to be based on data. Should I have been surprised that I didn't see any dead bodies in the cafeteria? And another example of that would be if I go to a hospital where 95%, supposedly 95% of the central lines are placed with effective hand washing. What could I expect the reality to be? Is 95% of the time is effective hand washing practiced? So, what do you, essentially are all the measures pretty good right now, and we just need to modify them a little bit, or do half of them need to be taken back to the drawing board to start over?
So the answer is yes and no. The most exciting word I heard this morning when Drs. Long and Jones were making their sort of opening remarks and setting the stage was the word verifiable. Because, if you live in Washington, it's very, very common for systems and others to come in and announce that they have achieved the triple aim. They may not even use that language, but we have, in our corner of the universe, we are doing the best possible job. Unfortunately, since we do the annual report on quality and disparities, I'm not seeing it yet. And we do a whole lot of cost analysis, too, and we're not seeing it there either. So that's the problem that I have. I don't think that we know enough about, in a sea of possible things you could measure at one institution, if you take a selective view, how accurately that represents the whole. I think that's an area of ongoing inquiry and learning, which I think is very, very important, referring to your visiting UCLA. The other thing I know is for people who've been seriously in the trenches, nobody gets to 95% of hand washing. Nobody. I mean, it takes an enormous amount of work to get to 80.
Helen.
Yeah, so it's a great question. It's a yes and no, I think, as Carolyn points out. I think there are some measures that simply need to be retired and put away. And measures that are at 98% performance, where the hospital spends all their efforts finding the last 2%, don't add anything. They just add to the cacophony, and they don't drive improvement. At the same time, some of those outcomes that are risk adjusted are really good, and I think they are representative of real data. I think the other thing, going back to this verifiable point, is as we increasingly move towards measures that are based on electronic data and hopefully bringing in the data from registries, they need to be auditable. We've got to have audit trails to allow us to, in fact, see that it is mirroring reality. And that's actually one of the benefits of moving to that platform, is you can actually begin to really do a more thoughtful audit trail.
So the one additional brief comment, measures have a whole lot of meaning beyond are they technically accurate, right? In many ways, they're a reflection of importance. So they have a whole sociological, cultural sense as well. And that's frankly all part of the challenge of getting to core metrics.
Yeah.
Barbara?
And part of what you're encountering is the different requirements established by the different accountability groups. And what locale, not accountability groups in terms of just the individual payers, but also what the local community thinks is important for measuring. And as an IT system, you're kind of stuck at the crux of it and hearing different responses.
It's interesting. It's another dimension to the dimensions that we heard this morning of this, the quality of the metrics that we're talking about. Also, several, in fact, I think every speaker, in effect, alluded to at least the idea of research to develop these measures and evaluate them. And I think it's an important dimension. Yes.
Hi, Tom Williams from the Integrated Healthcare Association, IHA, not to be confused with IHI. I have a question for Helen. It's a bit of a geek question. And we have been measuring total cost of care across provider organizations. And when you had your first call for resource measures, we were busy, and we knew Healthcare Partners was submitting theirs, and ours is very similar. And our thought was, when that was accepted, we would just rerun the data over past years. Sounds simple, but of course everything's more complex. We have a different risk adjuster, yada, yada, yada. So now you've got another call out, so we thought, well, should we submit? And we could, but then you'd have the IHA measure, and then later the Wisconsin total cost of care measure. And it just occurred to me, could we not take, and it's a powerful measure too, really important, could we not take that total cost of care measure, and obviously this is an example, come up with 3 or 4 different risk adjusters that you could use, a couple ways you handle capitation, et cetera, et cetera. I realize it doesn't fit with your process, but it's very frustrating to have 4 or 5 versions of a measure.
It's a great question. It's actually not very geeky at all. It's the reality of where we all live. And Greg Paulson, who used to be at NCQA, used to talk about there's HEDIS and then there's SHMEDIS. I mean, there's so much sort of variation in the way measures are even implemented, even if they're essentially, ostensibly the same measure. You're at least acknowledging they're different measures. Two somewhat different responses. The first is, I would love to actually get to the point where what we do is far more collaborative. What we'd love to do is get you and Health Partners and Chris from Wisconsin in a room and just say, what's the differences between these? Which is the best? I mean, can we just finally figure out and iterate towards what is the one that will work for everybody? Because ultimately, if you can't compare different regions, if you can't compare different systems, we're still stuck with where we are now, which is cacophony. So ideally, that's the right approach. The presenting options is fine as long as people then compare only apples to apples. And of course, we never know how measures will be always used and whether people will respect the fact that, you know, if I'm using this approach, only measure me against those who use that approach. It's complex, but I think ultimately we need to get to a much more collaborative environment where we figure out, kind of roll up our sleeves like the American College of Surgeons and CDC did with the surgical site infection measure. It took 6 months, but they said you can't have 2 national standards of surgical site infection. You've got to have one. And I think this is such a high-level measure, such an important measure. I would hope we'd actually go the extra mile and figure out how to make it align.
Well, if you want to try that with total cost of care, there's probably half a dozen people in this room.
We'll do it at lunch.
I think we should do it. All right.
Okay, we only have 4 minutes left.
And I'm Joe Lipscomb. I'm from Emory University in the School of Public Health and also the Cancer Center there. And just want to say that we are, in fact, using core measures in cancer in Georgia in 2 ways. We've linked the cancer registry to a number of public and private data sources and are monitoring metrics. And also we're working with the Commission on Cancer of the American College of Surgeons to implement a rapid feedback system for quality of care, and those measures in both cases are the first NQF quality measures that were endorsed in that project that we started a long time ago.
That, yes. Great.
But that's not what I'm up here about. I want to go back to Helen's slide, the one that said scope of future measures. And you got to this equation near the bottom, and it said, I believe it said outcomes divided by cost. And that's the inverse of the cost effectiveness ratio, at least the average cost effectiveness ratio. And we haven't heard the word cost effectiveness here. We haven't heard it actually in the reading materials. And there are reasons for that, I think. But the question is, we talk about optimizing the triple aim, and it leads to the question of exactly how does one think about this optimization? What's the thought process? It's not the same thing as saying who's the initiator, although that's part of it. It's also saying, well, what do we mean by an optimal optimization of that? So that's not an easy, that's a broad question, but I just, when I saw your slide, I said, well, we should ask that.
Yeah. I don't have an easy answer. I think it's really important. I think some of it is, be curious Carolyn's perspective on this. We had more time around how comparative effectiveness relates to cost effectiveness and how we really begin to get this broader frame. But it's a good question.
It strikes me that it's the integrator, or whatever the integrator is, that thinks about that, because that's really a value judgment.
Yeah.
You know, bringing the information together and then deciding what to do based on it, and you know, how to feed that back into the system. It's a good topic, as Carolyn just said to me. Actually, I think for the breakouts. Yep. Yes.
Kevin Larson from ONC. And back in my previous position when I was the CMIO of a health system, I was part of a collaborative looking at doctors and data feedback. And all of the, it was sponsored by the National Board of Medical Examiners, all the groups in that found the same thing. Doctors felt data was a weapon to be used against them. Doctors did not think of data as a tool or resource to help them drive forward what they wanted. And it made me really stop and think, and actually I was lucky enough to work under a CIO who was an educational psychologist who taught our organization that feedback is a gift. And every time someone gives you feedback, say, thank you for this gift. Thank you for this feedback. And really engaged our organization in thinking of feedback as a gift. So my question is, how do we do an intentional culture change where we move ourselves to feedback as a gift, people as in the country that are moving and driving to our aims and goals are intentionally wanting and seeking the feedback and using the feedback and its tools for improvement. Because as Patrick Conway so eloquently says, all improvement happens locally. And so unless we have them engaged as feedback as a gift, this won't happen. It will always be a weapon and a hammer. And so how is that part of our strategy, this culture change and this ability to sort of give people the desire to use the measures we have?
An important implementation topic, I think.
So when I asked some folks when we announced sort of national results from this, attempting to expand to hospitals across the nation, we got to about 1,100 in 44 states, you know, to reduce bloodstream infections from central lines. So what kept you going? And they said it was the results. That was the rocket fuel. Rocket fuel being my words, they were a bit more eloquent. The timely feedback, I think, would be incredible, timely and valid. I also heard about a system recently in a VA, which I thought was great. They have a monthly little competition across clinics in terms of how they're doing. But how their system works is it would say, Dr. Larson, you got 80% on your diabetes measures this month. The reason you didn't get 100 is because of the following patients. Click here if the nurse case manager or whomever ought to contact this patient for additional follow-up or whatever. That, I think, would get away from the weapons. The way it's deployed right now, we are stuck at a phase where I can't say, I have a lot of sympathy for people who feel that way. The cultural shift for me would be if they could say, how could we make it better? The just say no approach, I think that's over. And I know Dr. Crossan, who's here, is working very closely with the AMA to make that transition and to try to figure out how does this become value add. Right now, though, the whole enterprise is not value add for a lot of clinicians.
And just to add one thing, and I completely agree with the timeliness. I think if it's data you generate internally and you get it in real time and you can use it immediately, it's a totally different situation than when you get something in the mail 3 months later with no context. I mean, that I think is really important. But the other thing is, you almost wish we could take a deep breath as we sort of move towards heavy-duty pay-for-reporting and actually do pay for results, which is actually take some time, give clinicians a year or so to say, here's your data, look at it, understand it, tell us what works, tell us what doesn't work, let us kind of make the measure better, make you feel more comfortable, and then move it out. But I think in this sort of haste to get the measures, there's a sense of desperation. We want to get the measures we need to move it forward. Sometimes it feels like we're going a little too fast on measures nobody's seen, nobody's used, putting them into place with dollars at risk, and I think it just creates a lot of anxiety. Some of it that could be constructively used by giving them a chance to actually examine it, own it, understand it, and then believe it as it comes out. And Blue Cross Blue Shield in Massachusetts, for example, does that. They have as one of their principles. They will always have a period of performance for 1 year where clinicians get to see the data, report back before they put it in.
And certainly one of the things that we've heard from the different ACOs and the collaboratives that we've had to the table is the impact of having the clinicians at the table as part of the decision makers, not just the ones being given the measures to report.
Okay, thank you. We're a little over time, so.
Okay, I'm Lisa McGiffert with the Safe Patient Project, that is a consumers union project. And we are responsible sort of pushing out the laws to require hospital infection reporting. And I'm wondering if there are other really obvious measures such as that were not weren't on anybody's list to report back in 2003-04 when we started, and that actually stimulate significant change in the infrastructure of hospitals. For example, in the implementation of these laws, we've discovered that hospitals didn't have a system for documenting infections. They didn't have infection prevention experts and enough to do the work. Some of them did, a lot of them didn't. So there was this whole infrastructure that had to be built around the reporting, and hopefully it's not just about the reporting. I don't think it is. But I'm wondering if there are other measures like that, and I'll say the ugly M word, that a mandate would stimulate a change, because something like that can't be done voluntarily.
I guess I would say we need a lot more information about what information and measures the public values. And that has not been a big part of what we've done to date. Now, healthcare-associated infections have the incredible value, to some extent spurred by your own organization, but many others, that people get this. This is a what's wrong with this picture challenge. But figuring out what are the other situations where people would really want information, and do we have measures, or do we need to develop some? Do we need more science, and so on and so forth? That, I think, is a huge challenge.
Yeah, and some of the measures that have moved the needle, things like delivery prior to 39 weeks, or some of the sepsis resuscitation kind of bundle work. It's interesting. You almost wonder whether a mandate's needed anymore, or is it really just that those measures move the needle and people recognize it and they pick them up? So it may also just be temporally a very different time, Lisa. It'd be an interesting thing, I think, for us to sort of think through collectively with consumers.
And as the payment incentives go into place, they have an incentive to pay more attention to quality.
Yeah.
Okay, last question. You stand between us and lunch.
Mary Barton from the National Committee for Quality Assurance. I just wanted to take the opportunity to this terrific panel to ask you, as a measure developer, we love to get feedback, right, from NQF, and we work to harmonize as best we can. But I wonder if any of you have any thoughts about how that enterprise might be paid for in the future, and how we could think about ways to facilitate and align appropriately the incentives for California to work with Minnesota, not to mention NCQA.
Right. I'm not sure I have the answer, but I will say I think one piece of this is there's such limited information out there about who's working on what. So we've been toying with the idea, for example, of a measure incubator. At least you know Wisconsin's working on this, IHI is working on this, and Health Partners is working on this. Before you get too far down this path and invest a whole lot of resources, could you work together? I think the question is, could we then work with some of the sponsors of measurement to say, hey, we've got a coalition of 3 or 4 different groups who have come together and they think this is really important. Can we fund this? I'm not sure it's the total answer, Mary, and I totally hear your frustration, but I think unless we get earlier in the pipeline when there's sort of measure ideas or a twinkle in somebody's eye, it's going to be really hard to harmonize and kind of pick one at the end.
Well, I would also say that there's never been a dedicated stream, revenue stream, budget stream for measure development. I'll leave it at that. It does feel to me like it ought to factor into any future work on core measures.
Absolutely.
But learning networks can also be very effective with people coming together voluntarily and covering some of the costs of those discussions and having the exchanges.
Perhaps this can be a topic in the infrastructure session, as well as in the breakout. Well, please join me in thanking our speakers for a very thoughtful discussion.